Good morning, everybody. Thank you for the introduction and thanks for the opportunity to present to you today the Swiss approach to enable use and exchange of interoperable health data for research in order to reach the next steps for nationwide data networks. When defining the needs to drive data-intensive infectious disease research and practice, the National Institute of Allergy and Infectious Diseases of the National Institutes of Health in 2018 agreed that shared open access data sets need to be expanded and standards for data integration should be established. They particularly recommend that one should use new technologies for innovative data collection methods to foster data and metadata harmonization and to facilitate possibilities to combine individual data sets in terms of standardized data formats. I picked this example because this is an infectious disease conference, but actually the recommendations are basically true for every other disease area in which data-intensive research is being done. When we look at the data sources for ID research, there are in principle 4 electronic data streams. Medical data or routine data from hospitals or from other sources provide information on disease status, symptoms, confirmed infections, drug or vaccine-related adverse events on an individual or aggregated level. We have omics and molecular data in the ID research field, not only of the host, but also of the pathogens and vectors involved. We have participatory syndromic data where volunteers self-report basically their data. These do not provide any confirmed infection status for specific pathogens, but they provide individual health level data in near real time. And we have in addition non-health digital data derived from use of internet search engines, for example, social media or mobile phones. And these provide information on health-related behavior, including contact travel patterns, vaccine status, and so on. These are key for understanding and modeling disease transmission. Also here, we can abstract this information basically, and it's more or less true for all other areas of data-driven research in health. However, the main requirements for the data to be used remain always the same. Data needs to be findable, accessible, interoperable, and ideally also reusable. When we look at the data flow in a clinical research setting, it's already quite complicated. We have to take into account legal and ethical requirements, so participants have to be informed, they have to give their consent in order to take part in a clinical trial. An ethics board has to give approval to the research project. When it comes to the data processing, we have several information security and privacy concerns we have to be aware of. So the data should ideally be stored securely. And if we want to have third parties accessing these data, we normally aggregate the data or anonymize the data. That comes along with a certain information loss, but this is the compromise we have to do if we want to give out sensitive data, sensitive patient data to third parties. When we look now at the health data research setting, it gets even more complicated. There are various data sources and data providing institutions with different data governance, regulation, and expectations when it comes to the legal frameworks. So there have to be data transfer and use agreements, for example, established on top of the consent that patients have to give, on top of the ethical approvals. For example, when we look at the data types, we have many different data types, we have different standards, different formats. Data might also not be stored in one place. Data might be stored distributed, so we have to take care, when we think about the IT systems, we have to take care there is a certain interoperability between these systems. We want to reach technical reproducibility when we run our workflows in one data storage area and also the other. Depending on the methods, depending on the amounts of data we use, we might have high computing capacity needs here, which are not provided normally in clinical settings of a hospital, for example. And when we think of reuse of data to third parties, conditions for combining data sets, for example, have to be fulfilled. The data needs to be securely transported, and a solution for long-term storage with a view to further use of these data sets have to be found. And when we, again, in the reuse of data and data sharing, we have to be aware, if we do not anonymize the data or aggregate the data, the entire process of legal and ethical constraints has to go through, because that doesn't go away only because the data has been used once. So summarizing this, we can state nationwide data networks need fair data. Data has to be findable, accessible, interoperable, and reusable. The problem we have currently in Switzerland, but also in other countries, is that data is very often kept in a multitude of silos within very small total numbers in these silos. Basically, we miss catalogs that researchers can browse through in order to identify the data they want to include in their research projects, and we lack also metadata information. When it comes to accessibility, we often do not know who to contact. The data governance or data stewardship landscape is as wide as the data providing institution landscape. Everybody has basically his or her own idea how to deal with the data governance. We have the so-called lock-in privilege, so basically only those can access the data and do research with the data that coincidentally work in the very same institution where the data is gathered. And when it comes to the willingness to share, especially when it comes to big data sets that took a lot of effort, a lot of money to establish these data collections over time, there the willingness to share is still rather mediocre. Interoperability is still a major challenge worldwide. We have heterogeneity across data systems, and we know by now pretty well that, as the FAIR principles demand, an introduction of a formal, accessible, shared, and broadly applicable language for knowledge representation is very hard work. In terms of reusability, we need a proper description of data and data sets. We also have to fulfill the legal and ethical requirements here. As I said, this is not obsolete when we reuse data. And also we have to think about the long-term storage strategies, again affecting the F and the A of FAIR data. In order to tackle all these challenges and obstacles I just mentioned, the Swiss Personalized Health Network was launched as a government initiative mandated to the Swiss Academy of Medical Sciences on the one side and the Swiss Institute of Bioinformatics on the other side. It's a government-funded initiative with 68 million francs available for 4 years. The first phase of SPHN is basically to focus on university hospitals, on bottom-up projects, and on the BioMediT project, which I will introduce to you in a second. There will be a second phase of SPHN in which we will consolidate the network and also expand the network further. So the overall goal of SPHN is to promote the development, implementation, and validation of coordinated infrastructures to make health data interoperable and shareable for research in Switzerland. And this is done in close collaboration with our sister initiative. This is PHRT from the ETH domain, the Personalized Health and Related Technology program. So let me quickly summarize the facts, the key facts of SPHN. SPHN is a research infrastructure initiative and follows a decentralized approach. So that means we are not building a central data lake in the middle of Switzerland. Data is only being copied from the data providing institutions when it is used for concrete research projects. SPHN works towards a fair use of health data for research and a more democratic access to the data to avoid these lock-in privileges that I just described. We are establishing a national infrastructure, and this is not one infrastructure, this is an infrastructure network consisting of various modules and components, and we aim for improved data quality, for example, through structuring or introduction of harmonized data standards. And last but not least, We try to reach interoperability, semantic and technical interoperability of data within research projects, but also across research projects, across the entire system, and ideally over time, and of course nationally aligned with the global standards and the global community. So what kind of infrastructure components are we talking about? At the 5 university hospitals, research data management systems, or clinical data warehouses for research, as they were called, are currently developed with a connection to the biobank and sample information. So the hospitals came already a long way here. So basically all 5 university hospitals have now research data management systems in place. Moreover, we are currently deploying a distributed federated query system over all 5 hospitals in order to enable feasibility studies. So enable researchers to set queries into a combined data set of all 5 university hospitals. The SPHN driver and infrastructure development projects defined through this bottom-up approach, Adrian Egli's project, the sepsis project, and Carsten Burkhart's project is one of them, one of the SPHN driver projects you heard about this morning. They help us basically build the national infrastructure network and help establishing the framework conditions. For example, new technologies, innovative solutions for consent management, data governance, data collection, or de-identification processes are developed. Also, the establishment and maintenance of shared platform, data collections, and databases for research and healthcare use are supported within SPHN. And with the BioMediT network, a national infrastructure resource for secure data handling is being created, which can jointly be used by all Swiss universities, research institutions, hospitals, and other interested parties. As already stated many times this morning, interoperability is key and still one of the major challenges for data-driven research in the health sector. The landscape of health data standards, data formats, and data models is diverse, and it is clear that there is no easy one-size-fits-all solution when it comes to interoperability. And also every model or standards has its strength in a certain domain. So a standard that is useful for one particular area might not be as useful in another. This is why SPHN decided to develop a data-driven semantic framework consisting of 3 pillars. A strong semantic layer as a pillar 1 that leverages interpretability of health-related data by supporting data-object combinations. A model-agnostic, flexible technical transport and storage pillar, the pillar 2, that allows transport of data without affecting the semantic meanings and allows the highest degree of flexibility when it comes to data reuse. And as a third pillar, the data model should be defined based on the needs and requirements of the researcher and not based on the transport and storage model we decided to use. So when we look, what do we mean with compositional approach in the semantic framework? So basically the concepts, or we heard the word variables this morning, this is also true. The concepts are generalizable building blocks which can be used in different contexts. So each concept contains all information necessary to understand it by these attributes. And the concepts can be combined to composed concepts, which again can be combined into more complex compositions. So when we look at the example of a biosample as a concept, we have the information of the datetime the biosample was taken, the type of biological material we are talking about, and the body site from which the biosample was taken. So this is basically building the information for the concept of a biosample. The entire biosample can be combined with a sample ID, and we have the concept of a biobank sample. And when we combine the biosample with other attributes, such as, for example, a structured lab result, a time and a value and a unit, we basically conceptualize the concept lab result. These concepts have then value sets or terminology standards that are defined for each of them. And wherever possible, of course, SPHN looks at what value sets or standards are already established, for example, from eHealth Swiss or the Federal Office of Statistics when it comes to value sets, but also what is internationally used in terms of standards. So we're talking about LOINC, we're talking about SNOMED, or also FHIR when it comes to international standards that are already applied and also used for the semantic strategy in SPHN. When it comes to the storage and transport, we need, as already said, a description formalism that leaves us with a high degree of flexibility. It should be data model agnostic because we only want to transport or store the data. We do not yet want to use it for research within this formalism. And the concept need to be expressible without changing the semantic meaning. This is a very important point. In SPHN, we currently lean very much towards using RDF, the Resource Description Framework. The last decision here has not been taken yet, but it seems that RDF provides the best conditions here. It's a flexible triplet store. It is widely used already in the bioinformatics field. It is easy to query with Sparkle queries, and it could also be a good solution for outside of SPHN, because what we ideally want to do is define here a description formalism that can be adapted in other areas in Switzerland, for example, for the data reporting to the Federal Office of Public Health or the Federal Office of Statistics. Ideally, we would agree on one standard here. So what we are currently doing is basically we try to move forward with our semantic strategy, but of course it needs a lot of time to define the concepts, to define the attributes, because we have to do it in a way that it is modular, that it can be also used in a couple of years from now. So we start with project-specific determination or specification, but the idea is that over time we have more and more of the nationally harmonized data and data information, and the project-specific part is getting smaller. When it comes to data models, I already said it, there are numerous data models, and it really depends on what you want to do with your data. For example, CDISC is a mandatory model from the FDA. If you want to submit a clinical trial to FDA, you have to report in CDISC. HL7, healthcare interoperability, is used in the clinical setting. CDA, RIM, FHIR, these are all data models that can be used and are useful for one thing, but maybe not so useful for the other. So we agree that SPHN must be able to speak with everybody, and this is why we would like the choice of data model based on the needs and requirements of the research project, of the research group, of the community, of regulatory constraints or analytical constraints. So now we come to the data analysis in SPHN. In order to leverage the potential of health-related data for better disease prevention, improved medical practice, and innovative treatments, data needs to be interoperable, of high quality, and available for researchers in various disciplines, because as we heard this morning from Julia, we have to work transdisciplinary, interdisciplinary here when it comes to health data-driven research in health. We also need strong capabilities in clinical bioinformatics, computational biology, and computational service infrastructures are required in order to be able to integrate and interpret large and rich data sets, for example, including genomic information or transcriptomic or proteomic or metabolomic or imaging. Big data analysis and machine learning require high-performance IT infrastructures for computing and storage. And security measures for these ICT systems are necessary to protect the confidential or sensitive information from unauthorized use, modification, or loss or release. So combining all these requirements together, we basically a couple of years ago didn't have any IT service infrastructures that could provide these. And this is why BioMediT network project was launched as integral part of the Swiss Personalized Health Network. And the BioMediT network provides researchers with access to a secure and protected compute environment for analysis of sensitive data without compromising data privacy. BioMediT relies on 3 existing scientific IT environments. The nodes, this is the SIS, the node of the ETH in Zurich, the SciCore, which is with the University of Basel, and the Core IT node in Lausanne at the Swiss Institute of Bioinformatics. When we look at the data coming in from the data providing side, so routine data, omics data, cohort data, imaging data, depending on the data provider, of course within the framework that we set in SPHN, and of course in ideally harmonized data standards, the data provider can combine the data, pack the data, encrypt the data, and send it to the next BioMediT node. So in this case, this would be SciCore. The nodes are connected to each other, they operate under one information security policy, and they assure technical interoperability. And this is exactly what we were referring to before. When you want to run a workflow in SciCore, you should yield the same result if you run your workflow at SIS in Zurich. So the data is pushed to the next BioMediT node and transported to the node where the actual research is being done, and lands in an isolated project space, here as example in Core IT in Lausanne. The researcher has the key to decrypt the data and is provided with a cutting-edge technology compute environment with a configurable software stack, with storage and compute capacities, with backup and archiving. The researcher can log on to the central portal here. The researcher doesn't care where his data or her data sits, basically can access with the 2-factor authentication, with a single sign-on using the Switch EduID, and work from his or her desk as they would do the analysis in their home institution via remote access to this secure and protected IT environment. To conclude, the key success factors of SPHN, 3 years into the initiative, we realized that the need for a common understanding of the vision and scope is great. We have to align what we want to achieve and how we want to make that happen. We need a commitment of all players to share health data for the benefit of society, so from the citizens, from the patients, but also from the hospitals, from other data providing institutions, from research institutions, and so on. We need the transdisciplinary approach between clinicians, researchers, bioinformaticians, machine learners, etc. We need fair data and nationwide interoperability of health data. We need nationally coordinated and supported data infrastructures, and ideally supported with a certain sustainability. And we need process innovation in research, but also in the healthcare system. We are convinced that healthcare and research must go hand in hand in the digital learning healthcare system of tomorrow. Also, we are convinced that higher quality of data at the moment of capture would save a lot of money on the back end, because at the moment our interoperability efforts are only met because the data is transferred basically into the requirements that we set with the interoperability standards. But it would be much easier if data is already captured in this way, so that other people can also profit, and this transition does not have to be done all the time when we use routine data, for example, for research. Our biggest challenges still are scalability, so we would like to enhance the network we are currently working in on the global scale, but also we would like to have scalability in all the little infrastructure components we are currently building, because we never know what tomorrow brings. We would like sustainability in the system, so we would like our network, our infrastructure network, to survive the funding period of SPHN, so beyond 24. And a big challenge we can find basically in all the little aspects of SPHN is there is a big need for a cultural shift in terms, for example, of sharing data, in terms, for example, also when it comes to regulatory expectations, because the mass of data nowadays available bring other requirements, and also the laws have to, of course, be conceptualized according to this. Thank you very much for your attention.